hopefully won't run out of time, but the topics here, just to be honest, are pretty useless. Like this whole topic of is not very practical, but it shows a lot on exams on an OCAP. So you're going to see a lot of it, and occasionally you see a patient or two in the clinic too, but it's very didactic. It's very practical, but we also look about this, and I bet you're going to forget very soon. And the next year, we're going to talk about this thing and review the same thing, really for the OCAP. But there is also some practical importance to it. Let's see if I can. Okay. So this is just a list of things we're going to talk about. We're going to von Hippel-Lindau, or VHL, and then Wyburn-Mason syndrome, cavernous hemangioma, tuberous sclerosis, neurofibromatosis 1 and 2, Sturge-Weber, and ataxia telangiectasia. There's a list of things we're going to go through today, and hopefully you can remember something about some of them. Okay, so a pretest. So this is, I'm not going to call names or PGY level, but just for you to have an idea of what you do right now, and hopefully afterwards you know a bit more. All right, so case 1, 31-year-old female, and just try to remember the name of this lesion. Look at these chunky arteries and veins, and they seem to be connected and around the nerve. Like these parts of the retina seem to be kind of spared, but these upper parts are involved. So try to remember what the name of this lesion is, and what syndrome is this associated with. So the name of the lesion, what syndrome this is part of or could be part of, and what would you do if you see a patient like this? This is fairly common. I said these are useless topics, but this is actually, you see this type of thing as a red person, you see this from time to time. So what would you do for this person if it comes to your office? Case 2. So this is a child, 8-year-old child. You're doing your rotation as sick kids, wherever your pediatric rotation, and the pathology sends you the person. An 8-year-old girl has this lesion on her leg. So, and this person also has history of seizures. There's been seizure episodes for this child. And what's the name of this lesion? Try to remember the name of this lesion. And what's your working diagnosis? A child with this lesion on the skin, history of seizures. What are you looking for? What syndrome would that be? And then what are you looking for as an ophthalmologist in her eye? So a child with this lesion, what's in the eye? Another pretest, another case. So you have this older man with this lesion on his sort of V1 and V2 distribution. It's unilateral. What's the name of this lesion? This is fairly common as well. And is it inherited or not? And again, what are the eye conditions you're looking for? What things is this associated with when it comes to the eye? All right, so write your answers. Make sure you kind of, hopefully you can, if you know already, that's great. If you just review them, if you don't know, hopefully you'll learn something at the end. And in case 4, this is a sort of an adult, 34-year-old male. And then this is discovered in this person. Is this true or false? Is this always a bilateral condition? Yeah. Or no, it can be unilateral, true or false. And again, true or false, it is always an inherited condition. First of all, just try to remember what the name of this was. What is this? I have a chunky lesion here. You seem to have a feeding artery and a draining vein. So what is this? Always unilateral or not? Is always inherited or not? And is always, can this be monitored safely or not? So it's can be monitored safely. Okay, let's get started. So this seems to be similar to the lesion we just saw, but just another thing. Okay, so can one of the PGY4 shout out the name of this disease, this condition?
So this looks like a capillary hemangioma.
Very good. So it's a capillary hemangioma. It's part of von Hippel-Lindau. Usually goes the syndrome, von Hippel-Lindau, the whole syndrome von Hippel-Lindau, or VHL. And then what it is an autosomal dominant syndrome. Most of these are autosomal dominant. If you're in the test and you're stuck with something, you have to choose something, just choose autosomal dominant. The chances are you're going to be right. It usually shows itself in someone in the 20s and some younger adult person. It's a cancer syndrome. So you just have to remember that. It comes with other things. So obviously you have this thing in your retina, it's a capillary hemangioma, Sam said. You have cerebellar lesions, Pons lesions as well. They can come with pheochromocytoma, so you have to do your blood work for that. Renal cell carcinoma, this can actually kill them, the renal cell carcinoma, and then other type of cystic lesions in body, kidneys, pancreas, reproductive organs. So this remember, VHL is a cancer syndrome. They can die from renal cell carcinoma, and they definitely need workup. They need systemic workup for visceral tumors and also for head and neck tumors, especially cerebellar tumors. So this is an IVFA, another person. So you can see nicely the draining vessels and the feeding and draining vessels. And again, what does this mean? You have when that person you find in the clinic, someone sent to you, and this is discovered. Is this an urgent situation, or you has to be treated? Can be monitored. So let's go to one of PGY2s. Can someone shout out? Is this important or not? Any PGY2? Do we have anyone? Or PGY3?
Yeah, I think it's pretty important if you recognize this. Like you said, it requires a workup, especially for renal cell carcinoma, but also they can die from cerebellar.
How about the eye? Would you do anything? Say you send them to systemic workup. Do you have to do anything about the eye lesion?
I know you can consider they can get like a VH or like or like an RD from this. So I think generally if they're asymptomatic, you can monitor.
Yeah, this is important because if you see this, you got to treat the eye because as Aaron just mentioned, you can have vision loss. You can have vision loss with this. So capillary hemangioma, 50% you can have vision loss from those things. It's can rupture. This can VH, traction, detachment, exudation. And in a third of cases, this can be bilateral and multiple. And those are cases that are usually associated with the VHL syndrome. So not every capillary hemangioma is VHL. Remember that. So this can be in isolation as well. But especially over bilateral or multiple, they are usually associated with VHL, but not every case. And then cerebellar disease, as I said, is common. That's a type of lesion that affects the brain region. And then you got destroyed. You got to somehow ablate this lesion with laser, with vitrectomy, somehow ablate the lesion. And then you got to follow them again systemically. And for the eye, they can have new lesions, obviously. And then for VMAs, for the urine, for FEO, brain MRI, abdominal imaging, because it's a cancer syndrome. VHL is a cancer syndrome. Okay, so this is the same, not the same, same disease, but a different person. So let's just pick on one of the senior guys. Maybe Brian or Sam or someone else. What's happened to this eye before? What do you see in this eye that naturally is not present?
Well, it looks like there's a lot of maybe.
But what's this? Do you see my arrow right there?
Do it again. Sorry.
Do you see my arrow on the screen or no?
You don't. Not.
Oh, sorry. Okay, right superior to the nerve. There's some like bubbly stuff. What's that?
Silicone oil?
Exactly. So this is the sheen of silicone oil. So this had vitrectomy. Why did you get vitrectomy in silicone oil? You had bad TRD. So this is also like a TRD, bad TRD. And if you look below the lesion, there's a type of round lesion right there. Some curve doesn't go to the screen. I'm sharing with you guys. Sorry. So you can see a fairly large lesion, kind of whitish on top and red on each side of the white lesion. That's the big capillary hemangioma that's caused exudation and traction attachment and needed vitrectomy and silicone oil. So this can look pretty ugly, and that's why 50% they lead to vision loss. So this cannot be watched. All right, and let's see the next lesion. All right, so this any junior resident? What is this? Do we have any junior residents? You're the most junior person around here.
Okay. It looks like a racemose hemangioma.
Yeah, racemose hemangioma, exactly. So So, and this is part of Wyburn-Mason syndrome. So when you have a racemose hemangioma or racemose hemangioma, it's not a true tumor. This is an AV malformation. You can grade this, and if you want to be very academic, grade 1 to 3. They can have RVOs, they can have exudation, but it's rare. This is a fairly benign lesion to have. And a lot of times they get discovered later on, and people don't know. Some optometrist or some ophthalmologist discovers it, but it's generally a non-blinding disease. It is congenital, but not hereditary. And a third of them can have other AV malformation CNS. That's important to know. So if you see this, there is other associated sort of cerebrocerebral AV malformations, and especially in the face. So you can have ipsilateral head, neck, CNS, mandible bleeding, and dental work. So this facial AV malformation is associated with this Wyburn-Mason syndrome. So say if you have someone who comes to clinic with this, and this is, I would say, among all these diseases we're going to talk about, this is the most common that you're going to see for sure. And then if you see someone, don't ignore it, either yourself or someone else. Send them for some imaging, because you're looking for facial and central AV malformation. So I would do a CTA or MRA, or get someone else to arrange that. So and this is just interesting. This is a raceme, it's a type of flower. That's why it's called racemose. So it looks like a raceme. Apparently, that's why this name comes from. I don't think they're very similar. But I'm trying to figure out why this is called racemose, but it is. Okay, Wyburn-Mason syndrome. Okay, so this is a more advanced thing. So like just more of these AV malformations involving all 4 quadrants of the retina, but still the same thing. You have an AV malformation involving more. Again, the eye usually sees fine. You don't have visual problems, and you probably will not have visual problems, but you got to rule out CNS and facial AV malformations. And if you do a fluorescein angiography in this very person, you don't have any leakage, and then so usually you just leave them alone from the eye perspective. Okay, so this is a little bit less common, a lot less common, kind of more harder to diagnose. Maybe I'll just go to PGY4s again to tell me. Could you, Brian or Sam, could you shout out what this could be?
It looks like a cavernous hemangioma.
Excellent, excellent, very good. So, and you see cavernous because it has its caverns, right? So the cave-like ventricle looking things and bubble looking things in the retina. This is very uncommon, but you have these cavities that have half blood, half serum. Really. So you have these layers of blood in these cavernous spaces because there's little flow. So the blood actually falls down the bottom, and then on top you have clear plasma. So these grape-like lesions, the saccules, and then usually have someone in your 20s, slow growing. These can rupture, rare, but that's actually how they present a lot of these cases. They come with vitreous hemorrhages. And then you have other hemangiomas, cavernous hemangioma in the eye, usually part of the brain. You could have other intracranial and skin hemangiomas, and they come, it's osmolar dominant. They come with retina, skin, and CNS lesions. So they have cavernous hemangiomas. We don't have like a syndromic name for this thing, but if you have a cavernous hemangioma, it's an osmolar dominant. You can look for other things, CNS and skin. If you have an IVFA in this person, if you look at this, as I said, the blood and RBC just settle in the bottom. So your IVFA, each of those saccules is going to look black in the bottom because there's just blood and it's not flowing very much. Your fluorescein, the plasma serum part of your blood, is going to go on top. So each of those saccules, if you look at it, they're brightened up on top because that's where the serum is. And this is as characteristic as it's going to get for cavernous hemangioma. Any questions, guys, so far? So far, so good? Okay. So again, slow filling, IVFA, hypo early, and upper portion becomes hyper as the lesion fills up. And the blood is obviously very stagnant there. All right, so let's see. Any takers for this? There are 2 lesions in this person, right? So This is, first of all, it's in a younger person. You can see that, you can probably guess that from the big reflective sheen of the ILM in this picture. There are two lesions, at least, there's really three, but two are kind of obvious. One is next to the nerve. You can see the obvious lesion next to the nerve, and one is alongside the superior arcade. And if you really pay attention, there's another one along the inferior arcade. Any take for this?
This looks like astrocytic hamartomas in tuberous sclerosis.
Very good, very good. So these are astrocytic hamartomas. There are multiple of them, and that actually is going to argue something like tuberous sclerosis, as Rich said. Okay, very good. So your condition here is tuberous sclerosis. You have lots of hamartomas, and this is an autosomal dominant condition. They get hamartomas in the eye, obviously. They get in the brain, they get in the skin, in other organs, and rhabdomyomas, kidneys, liver, thyroid, and a lot of seizures. These are kids. So if you see someone or hear the name of tuberous sclerosis, is usually a child. The reason for that is that they usually die early. These kids die early in the teenage years, or even before teenage years, they pass away because of the high percentage of brain abnormalities. They get, a lot of them get seizures, they get mental deficiency seizures, and adenomosebation, which is not very common, but it's kind of very characteristic. It comes in, you see this in pictures. I'll show you a picture of it. And then astrocytic hematomas, as we said, a lot of them around the nerve, like this picture you have, and have a short lifespan. Most of them, not all of them, but most of them, they don't live very long. And as you can see, those lesions are kind of looking a bit different. So some of them are kind of very mulberry lesions, kind of very distinct. Some of them are kind of less distinct. So these are some of the or sort of systemic associations with tuberous sclerosis. Right on top, Amri, since you mentioned this, I'm gonna get you. So what's that lesion that they get over the cheeks and over the nose, top right?
Those are the facial angiofibromas.
Excellent, excellent. Or adenomosebation, facial angiofibromas. And then not everyone with this has tuberous sclerosis, but this is very characteristic of this. How about the one and the bottom? You don't have,
I think it's the ash leaf spot, like the hypopigmented macule.
On the bottom left is ash leaf spot, exactly. And the one on bottom right is shagreen patch, right? And the one in the middle bottom is what called ungual or periungual fibroma. You get these fibromas a lot, and then around the nails, you get these other tumors. I guess we reviewed all of them: adenomosebation, ash leaf spot, shagreen patches, subungual fibroma, the systemic association with tuberous sclerosis. From your end, you're looking for the astrocytic hamartoma, like in this picture, right? So this is another person with the same thing. There's very distinctive spine. Almost you see the calcium bubbles on this lesion. Again, rarely vascular supply, so there's no exudation, there's no VH. It can be a round, oval, or mulberry. This is more like mulberry, looks like a white blackberry rather, so you have this around the nerve, about 50% around the nerve, but as the other person you saw, you have it around the arcade or anywhere else. They're hard to look for, so you have to look for these lesions. A lot of these are kids sent to you, pediatric ophthalmology, sent by other doctors. And you got to rule out astrocytic hamartomas, which are astrocytomas essentially in the eye. So you have to look hard because all of them are going to be Galarian like this. Some of them are going to be very small, kind of very indistinct. They're calcific, so they're going to fluoresce. So if you have an FAF to do it, it will be very helpful. We can do it in that child. So probably an Optos FAF would be helpful. And treatment really needed because the eye itself is not going to have trouble, but they obviously have very significant systemic issues. This is another person with tuberous sclerosis. You can see the brain. If you take a simple CT scan, have very distinct calcific lesions, subependymal and subcortical calcific tubers. And these lesions are called tumors. And then tubers are calcium deposits, and obviously show easily on the CT scan. Okay, so we viewed tuberous sclerosis. this is something that looks the same, but it's very distinct. It's very, very common. You see it outside in grocery stores sometimes, people with these lesions on their skin. Any takers for this? What are
Those look like neurofibromas.
exactly? So this is a neurofibroma. So the condition is neurofibromatosis type 1. It's very common. 1 in 3,000 people have this. Again, autosomal dominant. If you get stuck, you had to choose something, choose autosomal dominant. Chromosome 17. If you add up all the letters in neurofibromatosis, it becomes 17. So I guess that's mnemonic, but not a mnemonic person, but these are very exam-oriented topics. Cafe au lait spots with axillary freckling, very part of the whole syndrome of type 1. And then these fibromas are glial tumors. So these are cells that support the regular. Sorry, my Hello Siri started to give me answers to random things. And then you have these neurofibromas, which are essentially supporting cells of neurons. You have discrete plexiform. When it becomes plexiform, it's the bag of worms, especially in the eyelid. You can see around the eyelid, associated with glaucoma very much. Anything symptoms that you have the upper eyelid related, you have 50% chance of glaucoma. So any of these things that affect the eyelid, you have very high rate of glaucoma. Maybe just physical reasons, maybe your drainage system of the eye gets impaired. I'm not very sure. But if you see involvement in the eyelid, look for glaucoma. Again, when it comes to the eye, Amrit or Aaron, what are those lesions on the iris here?
You have Lish nodules on the iris and the optic pathway gliomas on the scan.
Beautiful. So those are things that we as ophthalmologists, usually you're dealing with a pediatric patient because these are recognized early on. You're looking for these. And the number of lesion nodules increase throughout the years. They kind of correspond to decade of life because they increase as the person ages. So optic nerve gliomas, they're not very symptomatic. So sometimes the decision to do an MRI on this person, some people don't do it because they say, what am I going to do about it? And it doesn't cause any trouble. You have sphenoid hyperplasia. This is a very exam favorite issue in neurofibromatosis. You get sphenoid hyperplasia, scoliosis, lesion nodules that we just talked about. And then these choroidal lesions, hyperpigmentation on the choroid. I guess similar to lesion nodules on the iris, they get the same thing on the choroid. And it's the same really uvea, so I guess that would be the same thing. I never seen that, but I've seen lots of lesion nodules. Astrocytic hamartomas, again, similar to what you see in tuberous sclerosis, but not as prominent. It's not a prominent feature of neurofibromatosis. And then leukemia rhabdomyosarcoma. This is also a cancer, but very specific things usually. Okay, so to diagnose NF1, this is also an exam favor. You need 2 out of 6 things. We have all those other associations, but to formally diagnose someone, you need 2 out of these 6 things. So it's easy to diagnose someone, obviously. You only need 2 of these. You need more than 6 cafe au lait spots, which is the skin lesions. You need 2 neurofibromas or 1 flexible neurofibroma. You have axial or axillary or inguinal freckling, and this person has freckling in the axillary region, more than 2 lesion nodules, sphenoid hyperplasia or thinning of the long bone of the cortex, and first-degree relative. So this is easy to achieve. First-degree relative, you just have to have someone with that in your immediate family. And then if you have that and you have 2 lesion nodules in the eye, that's it, you have the diagnosis. But I will try to memorize this list. This 2 out of 6 gives you diagnosis of neurofibromatosis. When it comes to the eye, again, we are looking for lesion nodules. We are looking for some choroidal lesions in the eye, sphenoid hyperplasia right behind the eye, and then you have sort of glioma of the optic nerve, just as the other person had it. Okay, this is a less common condition, neurofibromatosis type 2, and as you can see in this picture, it's an acoustic neuroma also get an eighth nerve, they get a neuroma. It's a schwannoma, I think. And it's obviously not as common, and the eye associations are not very common either. Chromosome 22 apparently for neurofibromatosis too. They get bilateral carcinoma because if it's inherited disease, they get bilateral. It makes sense. The ophthalmic features of NF2 kind of controversial. Not everyone agrees on these, but then in theory, you get posterior subcapsular cataracts, you get retinal hamartomas, and then you get combined hamartoma of retina and RP. This combined hamartoma and RP is an exam favorite, but this is the whole NF2. It's not common and it's not asked very much either, but just know those few things that's associated with NF2. Okay, any questions so far? You good? Okay, so we're gonna switch topics to something a bit more common than NF2, and this is this condition. Okay, so I'm just gonna again any takers, and Aaron, Amrit, any what lesion is this? What's the name of the lesion on the skin?
A port wine stain or nevus flammeus related to Sturge-Weber syndrome.
Very good. Port wine. Does everyone with port wine have Sturge-Weber?
No.
No, exactly. So not everyone. Majority don't actually. And Sturge-Weber, the port wine tends to be in the V1 and V2 distribution in Sturge-Weber. And then you have this facial hemangioma. It's a facial hemangioma. It's kind of enlargement of the vessels underneath the skin. So it's engorged vessels. And so you can get a big bounce when it comes to the eye. Obviously, that usually means glaucoma. And then you have these calcifications in the brain and seizures. So they get a lot of these vascular abnormalities in the head and brain. Sometimes you have even sort of a developmental delay. Sometimes there's no developmental delay, and sometimes there's seizures, sometimes there's no seizures. So from general sort of developmental perspective, they can be 100% normal. They can only have this in the eye and face, but sometimes there's association with some CNS abnormalities. And you can see the picture bottom right, the eye on the right side is bigger. You can see that. So this ophthalmos that you have, probably there's glaucoma. There's some scarring around the cornea as well. So they may have had some travel already. And you can see that person, the upper lid is involved with it, and that raises the chance of having glaucoma. We'll go to the eye associations. So what's this? Page by for us. Look at this is very. So look at the fovea. The fovea is the bottom right of the photograph. You see that? So this is the more peripheral. What's that?
It's like a diffuse choroidal hemangioma?
Exactly. So it's a diffuse choroidal hemangioma. It's very characteristically related to Sturge-Weber syndrome. And then, so these are other associations of Sturge-Weber. So you have glaucoma, 50% get glaucoma. And then you have these prominent epibulbar and conjunctival vessels. It's very characteristic. You have increased retinal or vascular tortuosity of the retina. They get RVOs, and they get, as Sam just said, choroidal hemangioma, and then occasional serous artery. Because not even Sturge-Weber, if you have choroidal hemangioma, even if you have a localized choroidal hemangioma, they can get speaking lesion. You might have seen this already. It's not an uncommon condition. They get a subretinal fluid pocket. So if you have a diffuse choroidal hemangioma, it cause more of that subretinal fluid pocket. So that's how you get the serous artery from a choroidal hemangioma. And I do have a patient with Sturge-Weber at Sinai. Have you guys seen that? Who has seen that with me? So I have a patient comes to Sinai with Sturge-Weber. He's a retired teacher, has a port wine stain on the right side. He has glaucoma, and he has, I don't know, a 10-year history of an RVO. He gets injections now every like 3 months or so. He still has a bit of CME with those injections, but he's from out of town, so we decided to just watch a bit of a cystoid macular edema. He just comes in for controlling his RVO. He doesn't have any seizure or anything as I know, but he has glaucoma, he has RVO as part of the whole Sturge-Weber syndrome. and then this another sort of diffuse choroidal hemangioma is hard to see. It's hard to picture. Apologize. And okay, so we finished with Serge Weber. Although this picture you can see in Serge Weber, in epi or vessels, tortuous vessels, but this is a different condition, and it's mixed together with the rest of phakomatoses. Any takers?
Is ataxia telangiectasia?
Very good, Amit. Okay, so ataxia telangiectasia or Lewy Barr syndrome. So I'm not sure. For some reason, the Lewy Barr syndrome thing comes a lot in exams. So just know that ataxia telangiectasia is also Lewy Barr syndrome. It is an autosomal recessive condition. It's a prominent exception to all the rest of these things that are autosomal dominant or sporadic. This is autosomal recessive. They have ataxia in childhood. This gets worse and worse, obviously. And that usually when you have ataxia, it's a neurological condition. So they have other neurological problems. They have ophthalmoplegia. They have mental retardation. They get other telangiectasia skin and the conjunctival telangiectasia, as you can see in the picture. And then they have an impaired immunity. They have hypoplastic thymus and impaired immunity. This is also an exam favorite. So for some reason, they get a hypoplastic thymus. Just remember this. In AT, autosomal ataxia telangiectasia, they get a hypoplastic thymus. So if you look at this, again, this is a skin problem. They get telangiectasia of the skin, as I said, and you can see the ear. If you see the earlobe, you get lost tiny vessels on the ear as part of telangiectatic vessels. Okay, any questions? We good? Okay, so let's go over some high yield points. So tuberous sclerosis, VHL, and neurofibromatosis, they're all autosomal dominant. So VHL is autosomal dominant, neurofibromatosis is dominant, and tuberous sclerosis is autosomal dominant. And as I said, ataxic telangiectasia autosomal recessive. Again, these are totally useless parts of a piece of information, but again, they can come up on the exam. This is pure memorization, but you got to know it. And anything with a W is sporadic. So Iber-Mason syndrome, which is has a W, so it's sporadic, and a Serge-Weber is also sporadic. So Serge-Weber actually has a gene. We know the gene for Serge-Weber, but it's a sort of it's not a germline mutation. That's why I guess it becomes germline. It could be lethal. So we know the gene for Serge-Weber, but it's inherited way, so it's not inherited. And then VHL is an autosomal dominant, as we just mentioned. As chromosome 3 has 3 letters. So 3 letters, VHL, chromosome 3. And then you have neurofibromatosis type 1, and 17 letters is chromosome 17, also autosomal dominant. Again, I apologize I feel bad giving you these things, but you got to know for exam for some reason. And anything that involves the upper eyelid is 50% chance of causing glaucoma. I mentioned that a few times already. So we have Serge-Weber syndrome and neurofibromatosis type 1. Those are lesions. Serge-Weber syndrome obviously big visual involvement. If it involves the upper eyelid, like my patient, it does cause glaucoma, very likely. And NF1, with those big bag of worms, neurofibromas, it can cause glaucoma. And then anything with capital S has seizure. So Serge-Weber, again, my patient, Serge-Weber syndrome, can have seizures. He doesn't have seizures, but seizures very common because they get all those enlarged vessels in the brain as well as the skin. And tuberous sclerosis, and these are the kids. Remember, tuberous sclerosis are the kids that have Ashleaf spot. They have sort of angiofibromas, and they come with seizures very much and don't live very much. Okay, so again, mother spot. So what was this lesion again? Who started the? Was it Sam? You mentioned this. So what's the name of this lesion again? It's a capillary hemangioma, right?
Yeah.
It's a capillary hemangioma, and then you can see the exudation already from it, right? So you can see the lesion already in the bottom. You have lots of hard exudates, and the lesion is starting to attach. So this is a lesion you got to treat. And so we have one hyperlinda, VHL, capillary hemangioma, this is a lesion seen, Wyburn-Mason syndrome, cavernous hemangioma, tuberous sclerosis, NF1, NF2, Sturge-Weber, and taxus angiotasia. Okay, so this was kind of quick and lots of memorization, and this is going to be repeated many times. You're going to forget many times, and hopefully everyone will remember it just a bit more. So let's do some post-test. Okay, so name of the lesion. Just review your thing. So this is Erasmus hemangioma, right? And what syndrome is this associated with? Wyburn-Mason syndrome. Very good. And what would you do? And this, remember, this is an adult. This is a young adult. It's incidentally comes to your clinic. And then what you do when you see this yourself or the family doctor, you got to arrange some CT or MR angio for this person, because you're looking for facial and CNS AV malformations. These people are at risk of having, when they have dental work, they can have a lot of bleeding when they have dental work, because mandibular malformations are also CT. So they have a tooth extraction on a root canal, and then you hit an AV malformation, you have a lot of bleeding. So you got to recognize that if you see a patient like this. But I mean, we have the advantage of seeing the vessels in the eye. The dentists don't. Okay, hopefully you got this better than the pre-test. Okay, so this is this is a kit that's sent to you by dermatology with seizure history. Name of the lesion. What was this? And what Ashley, yes, Ashley. And the working diagnosis is
Tuberous sclerosis.
Yeah, you have tuberous sclerosis. Very good. And then, and what eye findings are you looking for?
Astrocytic hamartomas.
Exactly. And remember, that's hard to see. It's not going to be a glaring mulberry lesions every time. If you have FAF, a large wide angle FAF, that's very good, because it's going to pick up those calcific lesions easily. But then those astrocytic hamartomas or astrocytomas, they're hard to see sometimes. Okay, so the third case, again, this name of the lesion again, I think I maybe mentioned that before. It's a port wine stain, right? And is it inherited?
Sporadic.
It's a sporadic, yeah. It's a sporadic. And what are the common findings, eye findings in this condition? Again, just mention a few of them. Glaucoma, right? Very common. RVO, diffuse choroidal hemangioma, and tortuous bulbar vessels. And then if you have a choroidal hemangioma, you can have CRT with it as well. Okay, and let's go to the last case. Again, true, false. This is always a bilateral condition. On the PG/4, this is true, false. Always bilateral.
False.
False, exactly. So it can be unilateral, it can be sporadic. It doesn't mean it is necessarily an inherited condition. So how about this one? This is always an inherited condition. I think we just mentioned that as well. So it's all false. It can be sporadic. Can be safely monitored or no. So what's the syndrome here? If it, I mean, some of these, this is a capillary hemangioma, right? So capillary hemangioma, it can be sporadic, but if it's more than one or bilateral, you're looking at von Hippel-Lindau, right? And von Hippel-Lindau can be safely monitored.
No, you want to investigate these patients because it's a cancer syndrome, and additionally, you'd probably want to ablate the lesion.
Exactly. The lesion has to be ablated. It can cause tractional detachments. It can cause exudation. It can cause a 50% chance of vision loss in eyes with capillary hemangiomas. So false. Okay, so that was it, guys. This is my last slide. Any questions at all? So I think that wraps it up. Hopefully you learned something. And again, this is very exam favored, not very